Yes, so I'm going to talk to you about all this wonderful work here. How does this, in fact, help us in terms of treating our patients here? So these are just some highlights which I already explained in the beginning here about diabetes, how common it is, and how many patients have neuropathy and how many have pain, etc., and what's the cost of it. And you all know it's a very important condition. We also know that many of these patients coming to us, we'll have to go to this one, that diabetic neuropathy, which is in fact explained or defined as a symmetrical length-dependent sensory motor polyneuropathy due to metabolic and microvessel alterations due to hyperglycemia and cardiovascular risk factors. Now, the diagnosis is sometimes not that easy. There are important conditions that need to be excluded here, and I've just listed some of the most important exclusion diagnoses, such as arthritis or arthrosis, malignancy, peripheral vascular diseases, spinal stenosis, etc. And here you can see some of the other conditions that you see when you see patients with, you just look at the foot, which are some of the differential diagnoses here in these patients. I always go wrong here. So the mechanisms and the symptoms we see, which has been highlighted by both Sylvia and David here, we know that these may or may not be related to fiber types. In general, we have the large fibers, which will in fact result in some numbness if you have a loss of that, while the small fiber affection will result in various types of pain and burning sensations, etc. Some of the potential mechanisms for the ongoing pain has in fact been highlighted by Sylvia here. This is a figure, the one to the right, is from the Sapienza group, showing what some of the various profiles, clinical profiles that you can see in some of these patients here. So there may be patients where there is ongoing pain, where there is loss of sensitivity, where there is hypersensitivity, and we have got these correlations between laser-evoked potentials and skin fiber abnormalities, which may allow us to, in fact, delineate certain clinical profiles in these patients. So we have gone some way in understanding some of the potential mechanisms that may be operating in these patients. The question is, can we in fact, from a rational point of view, address these clinical phenomena in terms of treating the patients? And in fact, there are many types of treatments available to us. And this is from a figure which Ian Gilron, Tony Dickinson and myself had in a paper a couple of years ago, where we looked at where the various types of agents may in fact act within the nervous system. And you have medications that may act more in the periphery. There are agents acting at the level of the spinal cord, and agents acting more centrally. And this is also highlighted in this next figure here, which is just looking at what happens, for example, at the level of the spinal cord. So what we have here is the primary afferent here, the postsynaptic neuron and interneurons here, and we have agents which may act on the ectopic activity, like the tricyclic antidepressants, carbamazepine, oxcarbazepine, lamotrigine, may exert their effect on such ectopic activity here. There may be agents acting more at the segmental level here, like opioids and valproate. On the postsynaptic side, the tricyclic antidepressants, opioids, and even memantine, which is an NMDA antagonist, may block hyperexcitability, and then descending control can be acted also by TCAs, the specific noradrenergic reuptake inhibitors. Even the SSRIs may have an effect also on descending control. So these are some of the current existing agents that are available to us in treating these patients. If you look at what is called numbers needed to treat, and you heard about this by Mr. Number Needed to Treat this morning, Andrew Moore, although he didn't talk about NNT, but nevertheless I will talk a little bit about the NNT. And here on the top you can see a figure which Nafinarop published a couple of years ago just in diabetic neuropathy. And here you can see for the various types of drugs, the SNRIs, tramadol, pregabalin, and you have NNT values which is around 5. Now, Nafinarop has just redone this for diabetic neuropathy. And here you can see for pregabalin, for gabapentin, for the SNRIs and for tramadol. And what really is striking is that the NNT values is in fact increasing these years. We don't have a clear explanation why this is the case. We've just listed some possibilities here why we see this increase here. There are more studies coming in, and some of the studies are, some of the calculations here are also based on non-published publications. So you might think some of these could in fact be negative studies, which would in fact tend to increase the numbers needed to treat. So, but there can also be new designs and longer lasting studies which could account for this increase here. Fewer naive patients may be available to us these days, and there may be other factors as well explaining this interesting increase in NNT values. So this is also illustrated in this figure here, which shows for painful polyneuropathy in 2010. Now these are all painful neuropathies, not necessarily only diabetic neuropathies, but the vast majority are in fact diabetic neuropathies. And this is the most recent one, the one which I just showed you for 2015. And again, please note that the NNT values here on the x-axis is not the same as up here. So there is clearly an increase in numbers needed to treat, as you can see there. So based on all these figures here, there has been proposal for, in fact, algorithms for how we should treat patients here. So people are, or in general, agree that the first-line treatments are the TCAs, the SNRIs, and the alpha-2 delta binding agents for peripheral neuropathic pain, including diabetic neuropathy. And then second order or second class of agents would be these agents here: topical lidocaine, topical capsaicin, tramadol, tapentadol, strong opioids, botulinum toxins for neuropathy. And more recently, the NUPSIC have come up with a recommendation which is called the Grading of Recommendation Assessment, Development and Evaluation, which is a grade system, just published in Lancet Neurology this year. And again, what it said is that drugs with strong grade recommendation for use at first line are the TCAs, the SNRIs, antidepressants, pregabalin, gabapentin, and drugs with weak grade recommendations, the lidocaine patches, capsaicin, high concentration patches, and tramadol. This is for all neuropathic pain, not necessarily for diabetic neuropathy. And finally, drugs with weak grade recommendation for use and recommended at third line is strong opioids and botulinum toxin. So all these treatments here are in fact symptomatic treatment. They are not coming to the cause. Now what we have heard so far is that we are really trying to look into the pathophysiology of diabetic neuropathy. What are the underlying mechanisms here? Can we come up with something which brings us a little bit further, getting closer to the mechanisms generating both neuropathy and generating pain in those that have neuropathy? So I don't have the answer to that, but I'll just give you a suggested role here and look on one specific type of agent here, the role of sodium channels in diabetic neuropathy, and how we perhaps may get some clues about this. Now, this is from a recent review here, looking on what happens in diabetic neuropathy. And what's known from, or suggested based on animal models here, is that there is an accumulation of ion channels and glucose transporters in the region of the nodal region and paranodal region of myelinated myelinated nerve fibers in diabetic neuropathy. So ion channels and sodium channels in particular may be one particular culprit for generating the pain. And I'll just show you this figure here, which is about what the potential of sodium channels as a driving, or abnormal sodium channels as driving the pain. The figure at the bottom here is in fact courtesy from David Bennett, which is not from patients with diabetic neuropathy, but in fact from patients with carpal tunnel syndrome, based on skin biopsies. And what is shown here on the right is that there is an increased number or increased potential numbers of ion channels in damaged nerve fibers from such patients here. And the question is, do we see similar things that might explain the pain in patients with diabetic neuropathy? And I don't have that answer, but that's something to work on. But let's see what could be the possible role for sodium channel blockers like lidocaine in patients with both nerve injury and diabetic and polyneuropathy. So the hypothesis is that a peripheral but not a central block of lidocaine will in fact abolish spontaneous and evoked hyperpain with no difference between nerve injury and neuropathy. And we in fact addressed this in a small study last year, in which we looked at patients that have peripheral nerve injury and patients with polyneuropathy. And these patients went through two types of treatments in a randomized fashion. Both have a complete block of their affected of their nerves here in the periphery, or an IV infusion of lidocaine 5 milligrams per kilogram. So, and we also use the the German Pain Network paradigm in order to look what happened to various type of sensory modalities while we did this type of block, the peripheral one and the central one, and did a detailed sensory map looking at things here. So here is an example for a patient with peripheral nerve injury, a 34-year-old male with traumatic injury of the left peroneal nerve, pain in the foot, ankle, pain intensity about 8. And when he had a complete block of his complete block, then the pain goes away, and so does the sensation to cold and other sensory modalities goes down very shortly. If he's given an IV block of lidocaine, you can see that almost nothing happens here in this particular patient here. And if you look on the kinetics here, you can see that the concentration following the IV block is much higher than the one following the peripheral block. So this, in fact, indicates that lidocaine here exerts its effect entirely by blocking peripheral input, probably by blocking sodium channels out in the periphery. Now, if you go to a patient with painful diabetic neuropathy, you don't see the same thing. Now, I have to say these are very few patients here, but if you give a peripheral block here to this particular patient, the pain goes down, and so does the sensation also to other sensory modalities. But if you give an IV block with 5 milligrams per kilogram, the pain also goes down here, in contrast to peripheral nerve injury, and so does sensory modalities, in fact. So I have to come back here. So what we really found was that following the IV block here, there was literally no effect with IV lidocaine in patients with peripheral nerve injury, while in patients with painful diabetic neuropathy, there might be, in fact, an additional effect. So this raises the question whether there is a central effect on lidocaine which is specific for painful diabetic neuropathy in contrast to other patients. Now, I have to admit that these are very few patients here, but there might be something about this story. So the question is, what about systemic lidocaine? Are there indications that in fact they do work, have an effect at central sites? Now this is not a new story, because there was a study back in 1987 with intravenous lidocaine infusion, same dose, 5 milligrams per kilogram, and the effect lasted for almost 8 days. Indicating that it's probably not related to the kinetics of lidocaine, where the lidocaine moves away very shortly. Similar, there have been, Nigel Calgott had also studies in an animal model, the streptozocin model, showing an effect of IV lidocaine. We have shown in nerve injury here that if you give IV lidocaine here, there is also a block of pinprick hypersensitivity, and ongoing pain goes down by IV lidocaine. We also did a study in which we looked on a nociceptive flexor reflex, which is a withdrawal reflex, which is a spinal multisynaptic reflex evoked by stimulating around the ankle and recording from the biceps femoris muscle here. This was a paradigm developed by Jean-Claude Villers and Daniel Lebar in France many years ago, which is a very interesting polysynaptic reflex, and it's clearly blocked by IV lidocaine. These findings do suggest that IV lidocaine might in fact have an effect on other mechanisms than just blocking peripheral input. And in fact, my last slide is in fact from a very new, the last issue in Pain, in which there is an interesting presentation here where it is shown that there is a metabolic component of lidocaine, which is called N-ethylglycine, which is produced by lidocaine, and it has been shown that this one in fact increases the glycine transporter 1 at the level of the probably in the spinal cord, and that this effect that is seen by lidocaine could in fact be related to this increase in N-ethylglycine modulating the glycine transporter in the spinal cord. And there's also a commentary here suggesting that this might be a potential mechanism. So, although this is just a suggestion, but I think we now have the tools to go to a more mechanism-based approach in trying to treat our patients, because what I've shown so far is that the current symptomatic treatment of painful diabetic neuropathy is clearly insufficient. There are indications that the numbers needed to treat is in fact increasing. So we need to have what is called disease-modifying treatments for diabetic neuropathy, and of course in particular also for patients that have pain in addition to their neuropathy. So modulation of specific signaling systems is a clearly prerequisite for a mechanism-based management. Perhaps new sodium channel blockers may be one such specific type of treatment. So with that, I would like to thank you for your attention. Thank you very much.